Hello and welcome back to the Biochemistry for Health Sciences channel. In today's video, we shall discuss the milk-alkali syndrome. In the previous videos, we discussed several non-genetic causes of hypercalcemia, including the two most common, primary hyperparathyroidism, as well as cancer. And we also discussed other causes, such as tertiary hyperparathyroidism, vitamin D toxicity, immobilization, and in today's video we shall focus on medications, especially antacids and the milk-alkali syndrome, and we'll talk a little bit about the thiazide diuretics. First, a few words about antacids. These drugs that are often used to relieve the discomfort from gastric acidity. There are several types of antacids available. We'll just look at a few important examples. One is sodium bicarbonate, common brand name Alka-Seltzer. This is a water-soluble antacid. In the stomach, sodium bicarbonate will react with stomach acid to give you sodium chloride, water, and carbon dioxide. Carbon dioxide is a gas, so that will drive the reaction to the right. Therefore, sodium bicarbonate is considered a fast-acting antacid. The carbon dioxide will exit out of the GI tract, causing belching and flatus. Or the carbon dioxide could be absorbed into the bloodstream. Any sodium as well as excess bicarbonate could also readily be absorbed into the bloodstream. Now, the bicarbonate can directly cause alkalosis once it enters the bloodstream. Another antacid is calcium carbonate, TUMS. This is poorly water-soluble, very small amounts dissolve in water, but that small amount that does gradually dissolve in water will react with the stomach acid to give you calcium chloride water, and once again carbon dioxide gas, and this CO2 will drive again the reaction to the right, making calcium carbonate a fast-acting antacid. Some of this antacid is absorbed into the bloodstream. The carbon dioxide, as in case with bicarbonate, will exit out the GI tract or be absorbed into the bloodstream. But the calcium, about 30% of this calcium will be absorbed into the bloodstream. Magnesium hydroxide or milk of magnesia. This is again very poorly water-soluble. Small amounts of magnesium hydroxide that does dissolve in water will slowly react with the stomach acid. So that's a alkali plus an acid will give you salt and water. Magnesium chloride is the salt. There is no gas release. This is a very slow reaction, so magnesium hydroxide is a slow-acting antacid. There is negligible absorption of the antacid into bloodstream. Very small amounts of magnesium may be absorbed. It should be noted that magnesium can cause diarrhea. Another antacid is aluminum hydroxide, or Alterna gel is the brand name. Once again, like magnesium hydroxide, very poorly water-soluble. Aluminum hydroxide will react with the stomach acid to give you salt and water. In this case, the salt is aluminum chloride. And once again, this is a very slow reaction. So this is a slow-acting antacid. There is a negligible absorption of aluminum hydroxide in the bloodstream. So very, very small amounts of aluminum may be absorbed. It should be noted that aluminum causes constipation, and aluminum can also bind phosphate in the GI tract to form insoluble aluminum phosphate. Now, There are also antacids which are combinations of aluminum and magnesium. Example, Mylanta and Malox. So in this case, the aluminum will counteract the diarrhea effect of magnesium, since aluminum causes constipation while magnesium causes diarrhea. Okay, so with a little background on antacids, let's look at the milk-alkali syndrome. First, a little bit about the interesting history of MAS. So in 1915, Dr. Sippy introduced a treatment for peptic ulcer disease, and this treatment consisted of taking milk, which is very rich in calcium, and some alkaline salts. Remember, alkaline salts are salts made from a strong base and a weak acid. So an example of an alkaline salt would be calcium carbonate as well as sodium bicarbonate. Calcium carbonate is made from calcium hydroxide, which is a strong base, and carbonic acid, which is a weak acid. Similarly, this is from sodium hydroxide, strong base, and bicarbonate comes from carbonic acid, which is a weak acid. Now, in 1936, Cope reported that patients that were treated with this Dr. Sippy's treatment for PUD exhibited a triad of signs and symptoms, and this triad included hypercalcemia, high blood calcium, alkalosis, the pH is greater than 7.4, as well as a reversible acute form of kidney injury. In 1949, Burnett reported that patients who had prolonged treatment with Dr. Sippy's method not only had hypercalcemia and alkalosis, but now their kidney injury was an irreversible chronic form. And there was also tissue calcification seen in various tissues in these patients. So in the 1970s, cases of MAS declined with the introduction of non-absorbable antacids, proton pump inhibitors for treating PUD, as well as the histamine 2 blockers. Now, surprisingly, after 1990s, once again we started seeing increasing number of MAS cases. And in 2006, a modern version of MAS was introduced. This was associated mainly with taking high amounts of calcium carbonate, which was taken mainly for problems such as indigestion as well as osteoporosis. So since this was mostly associated with calcium carbonate, MAS was changed to CAS, calcium alkali syndrome. So what is the pathophysiology of calcium alkali syndrome? Unfortunately, it's very, very complex, and we still do not know the exact pathophysiology of CAS. But we do know that it involves typically ingestion of excess calcium carbonate plus some other factors. Okay, there are some other factors that are also involved in CAS. The one thing we do know that all of these CAS cases are characterized by the triad of hypercalcemia, blood pH being greater than 7.4, or alkalosis, as well as kidney injury. Due to the complexity of this CAS pathophysiology, we will look at a very nice case that will give us some idea of what may be happening in the calcium alkali syndrome. And this is a case reported by Arrow et al. In 2013 called the calcium alkali syndrome. It was published in the Baylor University Medical Center proceedings. So this case was about a 78-year-old female. She ingested over 50 tablets. Each tablet has about 500 milligrams of calcium carbonate, so over the period of 3 days. And when she came to the clinic, she showed weakness, malaise, as well as confusion. She also had dry mucous membranes as well as very poor skin turgor, which was a sign of hypovolemia, probably due to dehydration. Then she had several other problems in the past medical history, and this could be some of the other factors that might have been responsible for CAS in this patient. This included chronic obstructive pulmonary disease, high blood pressure, problems with the heart, also some kidney problems, chronic kidney disease, and she was on several medications, verapamil, that's a calcium channel blocker. It relaxes blood vessels to reduce the workload on the heart. Ramipril, that's an angiotensin converting enzyme inhibitor. It relaxes blood vessels once again. Warfarin is an anticoagulant. Ibentronate, that's a bisphosphonate drug that will bind to bone and inhibit the activity of osteoclasts. And then she was also on calcium as well as vitamin D supplements. She also showed the triad, hypercalcemia, which was probably genuine hypercalcemia because her albumin levels were normal. Albumin is the major protein among all the proteins in the bloodstream. Her calcium was elevated, greater than 10.4. Hers was 14.4. Even her ionized calcium was elevated. It should be greater than 1.3, and she showed 1.52. So clearly she had hypercalcemia. Her bicarbonate levels were elevated. Normal should be up to 28. She had 32. So that was a sign that she had alkalosis. And she also had kidney injury as shown by an elevated BUN. Hers is 35, much greater than the upper limit 18. The creatinine was elevated. She showed 2.9, much more than 1.3 as the upper limit. So before we get into her case, what do you think would happen in a healthy individual if his or her serum calcium is elevated? So you may want to review the ODME, origin, distribution, metabolism, and excretion of calcium that we discussed in video 9.5 to try to answer this question. So the answer to this question, what happened to an individual, a healthy individual whose calcium levels rises, is to lower the calcium levels down back to normal, especially the ionized calcium. And how is that done? Now, if you look at the ODME video, this can be done by absorbing less calcium from the GI tract. Now, in this case of this lady, she was taking vitamin D as well as calcium. The other possibility is to send the excess calcium into the bone, so that's called bone buffering. Now this lady was taking ibentronate, that's a bisphosphonate drug that affects osteoclast activity, so maybe that was affecting her bone buffering. Another thing that will happen in an individual who is healthy would be, if they have high calcium, get rid of the calcium. Okay, increase the renal excretion. However, in this patient, she did have chronic kidney disease as well as heart problems, and the heart and kidneys are closely associated, and that may be a reason that it could be one of the factors that caused CAS in this patient. So the patient with weakness, malaise, confusion, and we'll see in a future video, this is all symptoms that can be caused by hypercalcemia. Okay, hypercalcemia, calcium will cause problems with excitable tissue, especially nerves and muscles, and that can lead to all of these symptoms here. And then the dry mucous membranes and poor skin turgor, as we mentioned, is due to hypovolemia or dehydration, most likely due to dehydration. So what did the patient go through? When she was admitted to a hospital, the first thing the physicians did is they gave intravenous physiological saline to correct the hypovolemia, and of course they stopped all calcium and vitamin D supplements. On the second day of a stay in a hospital, the patient was lucid, awake, and able to communicate. Her calcium went down from 14.4 to 12.8. Her creatinine went down from 2.9 to 2.7. So she still had hypercalcemia and still the acute renal injury. But by the fifth day, she did not show the triad anymore. Her calcium was back to normal, 9.6. Her creatinine from 2.9 back to normal, 1.3. BUN from 35 back to normal at 16. And the bicarbonate from 32 back to normal at 27. So this is the proposed explanation about what might have happened in this patient. We'll look at this in three parts. In part one, we'll see how hypercalcemia led to an increased calcium reabsorption, therefore worsening the hypercalcemia. We'll see how hypercalcemia caused alkalosis by increasing bicarbonate reabsorption from the kidneys. And we'll see how hypercalcemia caused hypovolemia. In part two, we'll look at how hypovolemia activated the renin-angiotensin system, and then how the renin-angiotensin system, or RAS, increased bicarbonate reabsorption from the kidneys, thereby enhancing the alkalosis. And in part three, we'll see how the alkalosis then went on to worsen the hypercalcemia. Before we get into the explanation, a few words about these calcium-sensing receptors that we first discussed in video 9.7 on parathyroid hormone. These calcium-sensing receptors are found in many different cells all over the body. The main ones, example, are chief cells in parathyroid gland, parafollicular cells in thyroid gland, and in the renal tubules, as well as in several other cells located in the skin, stomach, colon, as well as bone. Now, one of the reasons why the pathophysiology of the Milk-alkali syndrome is still uncertain is because it involves the calcium-sensing receptors. CASR, or calcium-sensing receptors, signaling is very complex. First of all, there are several ligands as well as environmental factors that can influence these receptors. It can activate these receptors. For example, there are type 1 agonists. These are chemicals that can directly bind the receptors and activate the receptors. Calcium, of course, is the most important, but there are also several others, such as magnesium, as well as certain polycations, such as polylysine. And then there are several chemicals as well as environmental factors that can modify the calcium binding to this CASR, allosteric modification. These are called type 2 agonists, and this include polyamines, several amino acids, especially the aromatic amino acids, as well as changes in the pH as well as ionic strength of this environment here around the receptors. And then another complexity with these receptors is not only are they influenced by many different chemicals and environmental factors, but once they're activated, they can go on to activate several different G proteins. So this signaling is very promiscuous. Can go on to activate many different proteins, then go on to activate all kinds of enzymes, including adenylate cyclase, various phospholipases, and so on. The calcium sensing receptors along the renal tubule seem to play an important part in the pathophysiology of milk-alkali syndrome. So let's look at this a little bit before we get into the explanation of what might have happened in this patient. The CASRs may be located at the apical part, for example, in the proximal convoluted tubule. Most of the CASRs are in the apical part. In the thick ascending limb, where the highest concentration of CASRs are present, they are mostly basolateral. That means they are facing the blood vessel. In the distal convoluted tubule, they're mostly basolateral, but there are also some that are found on the apical part. And the collecting duct, they are mostly located at the apical part of the epithelial cells lining these tubules. So it is important to note that the chemicals or the environmental factors present in the cavity of the tubules, they will affect these apical receptors, while the environment of the bloodstream as well as the ligands present in the bloodstream, they will influence more the basolateral receptors. So with that background, let's look at part 1, how hypercalcemia worsens hypercalcemia, causes alkalosis, and induces hypovolemia. So our patient took excess oral calcium carbonate together with vitamin D, so that really got her calcium absorbed from the GI tract. So there's increased absorption from the GI tract, and that calcium ended up in the bloodstream, leading to hypercalcemia. Now, hypercalcemia would have constricted renal arterioles. We'll see in a later video that calcium will influence excitable tissue, so it will constrict the smooth muscles of blood vessels and thereby constrict renal arterioles, and that will reduce the GFR, and that would decrease calcium excretion because there's less blood coming to the kidneys, and therefore the excretion of calcium would be reduced, and that effect alone would have enhanced her hypercalcemia. However, this effect may have been decreased by her taking these drugs, verapamil and ramipril. These drugs actually help relax the smooth muscles instead of constricting the smooth muscles. Now, in the thick ascending limb of the loop of Henle in the patient, the calcium present in the bloodstream, that would bind to the basolateral calcium sensing receptors and activate these receptors. Once activated, there will be CASR signaling. Remember, this is complex and promiscuous, but here are some of the things that might have happened. One is the CASR signaling inhibited this transport protein called NKCC, sodium potassium chloride cotransporter. So this is the protein that is inhibited. You can see this protein brings in sodium as well as potassium as well as chloride from the cavity into the tubular cells. Another effect of CASR signaling is the inhibition of another transport protein, renal outer medullary potassium, ROMK. So this is the protein that will be inhibited. Note this protein brings potassium from the cell out into the cavity. So the effect of inhibitions of these two proteins would be there would be more sodium and chloride that would be excreted, and together with sodium chloride there would be also water that will be excreted. So there is increased sodium chloride excretion and water excretion or diuresis. Another effect is that the trans-epithelial voltage across the cell, where you have a positive here and a negative on this side. So this voltage, trans-epithelial voltage, is disrupted because of this inhibition of these transport proteins. Now this voltage provides the driving force for the paracellular transport of cations from the tubular cavity into the bloodstream. So without this voltage, the net effect now would be there would be decreased calcium reabsorption. In other words, more calcium would be excreted. Another effect of CSR signaling in the TAL that's been reported is that the signaling increases a claudin called claudin 14. This claudin inhibits the paracellular transport of calcium by this complex called claudin 16-19. So remember, these claudins are proteins that help regulate calcium transport by paracellular means. So this net effect of not having the voltage as well as increasing claudin 14 means that there will be decreased calcium reabsorption. In other words, increased calcium excretion at the thick ascending limb. So due to this decreased calcium reabsorption in the TL, a lot of this calcium in the TL will continue its journey, and a lot of it will then reach the distal convoluted tubule as well as the collecting duct. So the calcium from the thick ascending limb that is present in the tubular cavity will now reach the distal convoluted tubule, and here that calcium in the cavity, in the lumen, will activate the calcium sensing receptors present at the apical part of the cell. Meanwhile, the calcium in the serum, due to hypercalcemia, will activate the basolateral calcium sensing receptors. So the calcium sensing receptors signaling due to this activation by calcium will then lead to the stimulation of this protein, TRPV5, that will bring in calcium from the cavity into the cell. And once in the cell, then this calcium will be exported into the bloodstream by sodium calcium exchanger. You can see calcium goes out to the blood, sodium comes into the cell, as well by another protein called calcium ATPase. This protein will pump calcium out into the bloodstream. So that calcium will increase in the bloodstream, and that will enhance the hypercalcemia. The calcium that now reaches the collecting duct, this calcium, this lumen calcium, will now activate the apical CASRs that are present in the collecting duct. So this activation of the CASRs present in the apical part of the collecting duct is going to lead to CSR signaling. Now this signaling is going to cause an inhibition in the expression, the activity, as well as the trafficking of these very important proteins called aquaporin 2 water channels. These are proteins that bring in water across the membrane, help water transport across the membrane. So without these aquaporins, sufficient amounts of aquaporins present, and their their activity is decreased, there will be less water that will be reabsorbed into the bloodstream. In other words, water here in the collecting duct will be excreted. And this excretion of the water from the body is going to lead to this hypovolemia. Now, one good thing about this water excretion is it makes the urine very dilute. So if there is a lot of calcium present, the chances of this calcium finding phosphate or oxalate and precipitating, forming calcium stones is reduced. Okay, so calcium stone formation is reduced by diluting the urine. However, we will have hypovolemia because of loss of water, diuresis. Now, another thing the CSR signaling has been reported to do in the collecting duct is that it stimulates this proton pump. So this pump will pump protons from the cell out into the cavity. Now, these protons, remember, they come from this reaction. So which means that every time protons are being pumped into the cavity, bicarbonate is being transported into the bloodstream. And that transport is done by this anion exchanger 1, AE1. So as this protein is activated, more protons are pumped out. And, this proton pumping here will make the urine acidic, and that again will prevent calcium stone formation. So that's a nice thing about this acidity. However, bicarbonate appears in the bloodstream, and that will lead to alkalosis. And we'll see a little bit later that similar effect is stimulated by aldosterone. Okay, so this is part 1, how hypercalcemia worsen the hypercalcemia, cause alkalosis, and induce hypovolemia. Now let's look at part 2, how the hypovolemia will stimulate this renin-angiotensin system, and the renin-angiotensin system then will go on to worsen the alkalosis. Before we do this, the question, reminder, why is it that if your bicarbonate in your bloodstream increases, for example, by increased reabsorption, why does that cause alkalosis? We talked about this in video 3.4 on the Henderson-Hasselbalch equation, so you may want to look at this video. This is the most important buffer, the bicarbonate buffer in the bloodstream that maintains our pH at 7.4. So you can see if we use the Henderson-Hasselbalch equation, anything that increases serum bicarbonate, this is a constant, if this increases, the pH is also going to increase. So if there's more reabsorption from the kidneys and your serum bicarbonate increases, the pH is going to increase, and that increased pH is going to cause alkalosis. Okay, so the hypovolemia is going to lead to the activation of this renin-angiotensin system. Angiotensin 2 will be released. This will act on the kidneys. Angiotensin 2 will then also cause the increased secretion of aldosterone by the adrenal glands, and this aldosterone will also act on the kidneys, and both of these we'll see in a few seconds will lead to increased bicarbonate reabsorption. So let's look at angiotensin 2 first. This will bind to these receptors, AT1 receptors, which are present in proximal convoluted tubular cells. And this binding will trigger the G proteins, GS and GQ. And that pathway will then cause the stimulation of this protein, transport protein, called the sodium hydrogen exchanger, or NHE. NHE, you can see, transports protons out into the cavity in exchange for sodium. So more protons are pumped out while bicarbonate is reabsorbed into the bloodstream. So this bicarbonate reabsorption will enhance the alkalosis. So as mentioned earlier, angiotensin also stimulates aldosterone release by the adrenal glands. This aldosterone this would be aldosterone, ALD. The aldosterone will, from the bloodstream, enter the cells. Enter cells, especially in the distal convoluted tubule and collecting duct. Aldosterone, remember, is a steroid hormone. It will bind to these mineral corticoid receptors inside the cell, travel to the nucleus, and that will cause increased transcription of various aldosterone-induced proteins, and one of these would be this proton pump, HATPase. So increase in HATPase means more protons will be pumped out into the cavity. Bicarbonate will be reabsorbed into the bloodstream, and that will lead to the enhanced alkalosis. Now, this renin-angiotensin system is a very important system that we'll discuss in future videos. So just a little bit to note at this stage that aldosterone, which is stimulated by angiotensin, also increases the reabsorption of sodium as well as water by the sodium chloride cotransporter NCCT in the distal convoluted tubule, and this helps correct the hypovolemia. This also leads to increased potassium as well as acid secretion. Okay, so this is part 2, how the hypovolemia eventually stimulated the RAS that then worsened the alkalosis. Now let's look at the last part, part 3, how this alkalosis now worsened the hypercalcemia. So once again, we go back to the thick ascending limb. So now here we have not only calcium because of the hypercalcemia, that is binding to these basolateral CASRs, but now we have an increased pH because of alkalosis, which really means there is increased OH minus, and this is increased pH is also influencing the CASR. So it's going to change the protonation state and therefore the structure of the receptor. And by changing the structure of the receptor is going to change the affinity of the receptor for calcium. So basically it's going to increase the affinity of the receptor for calcium. So now this CSR signaling here, due to not only calcium as well as pH changes, increased OH, this is going to cause all these things that we talked about earlier in the TAL, and that is going to lead to more calcium from the TL entering the distal convoluted tubule as well as the collecting duct. Now in the distal convoluted tubule, the calcium in the cavity would stimulate the apical CSRs. However, the high pH now, so besides calcium, now we have high pH because of alkalosis, that would stimulate the basolateral CASRs. So we have not only calcium here stimulating this basolateral CASRs, but the increased pH due to alkalosis, as well as cavity calcium influencing this apical CASRs. So as we discussed earlier, this activation of CASRs present both on the both apical as well as basolateral membranes. This signaling will stimulate TRPV5. More calcium will be absorbed from the cavity into the cell, and then this calcium will be exported into the bloodstream, and that will worsen the hypercalcemia. So this is a possible explanation of what might have caused the milk-alkali syndrome or the calcium alkali syndrome in this patient. So the patient basically had Cope syndrome. The kidney injury was acute reversible form, because when the calcium and vitamin D supplements were stopped and the hypovolemia was corrected, the kidneys function seemed to have returned back to normal. Now, in some patients, this Cope form can be transformed into the Burnett syndrome. In this case, the kidney injury is a chronic irreversible form. So these patients also show hypercalcemia, alkalosis, renal failure, and there is also a lot of calcium precipitates in various parts of the body, various tissues. So the high pH, the OH ions, in the presence of excessive amounts of calcium, there's a good chance of this calcium binding to proteins and then binding to phosphates, oxalates, and so on, causing widespread tissue calcification. Okay, a few words about how thiazide diuretics, which are very common drugs used for high blood pressure, these drugs can also cause hypercalcemia. Now, thiazide diuretics inhibit the sodium chloride transporter, NCCT, in the distal convoluted tubule, and so this would mean less sodium as well as chloride is reabsorbed. That means more of sodium chloride is excreted. Together with sodium chloride, water is excreted. Therefore, this is a diuretic drug. So due to the NCCT inhibition, there's less sodium in the cell, and this will stimulate this protein, sodium calcium exchanger, to bring in more sodium from the bloodstream into the cell, while calcium is exchanged for the sodium. So any calcium present will be sent out into the bloodstream. So now the calcium concentration in the cell is very low. So if the calcium concentration in the tubular cavity is high, more calcium will rapidly enter the cell and be sent out into the bloodstream, and this will cause hypercalcemia. Now, thiazide diuretics, because they cause diuresis, volume depletion, that will cause the kidney at the proximal convoluted tubule here to reabsorb more sodium, and together with water. So with sodium, water enters. So more sodium and water will be reabsorbed at the proximal convoluted tubule, and this will give the driving force also for paracellular reabsorption of calcium. So more calcium gets reabsorbed by paracellular means into the bloodstream, and that will lead to increased calcium levels in the bloodstream or hypercalcemia. Okay, so with this video, we have now covered some of the major causes of hypercalcemia. Remember, these do not include genetic causes, which we'll discuss in future videos. So until the next video, once again, thank you very much for watching and supporting this channel. Goodbye and have a wonderful day.